It's such a pleasure to introduce a dear friend and a highly admired colleague, Dr. Clinton White, who is a professor and chief of the Division of Infectious Disease in the Department of Internal Medicine at the University of Texas Medical Branch in Galveston. Clint is really, to express it from the heart, is one of the best kind of experts and speakers on parasitic infections I've ever heard and interacted with in the United States. Actually, I enjoy his lectures to the extent that if I really want to learn a good update on malaria or some of these parasitic diseases, I get in touch with Clint or search a time when he's speaking. He got his MD in 1982 from the IU University in Indiana. He's finished his internal medicine residency in 1985 at the University of Washington in Seattle, and completed his fellowship training at Yale University by 1989. He has joined Baylor as a faculty and has been there since 1989 and served until 2007, where he really has been developed the international healthcare or health track for medical student, and has been really the expert as far as Baylor, as far as parasitic diseases. His work also extended to HIV and has been recently doing elegant work on Cryptosporidium. He is currently, as the chief of infectious disease at UTMB, is also involved in and has developed the global health tract for medical students, and continues to be intimately involved in global health and tropical infectious disease. He also has developed the NIH-funded Galveston Global Health Consortium. He has more than 130 publications in peer-reviewed journals and a total of around 200 publications, including book chapters and invited articles. Without further ado, Dr. White, we're very privileged to have you today.
Thank you. So I always worry when you get a nice introduction that all I can do is disappoint you. So Sam, I think you've set me up, right? Set me up for failure. So I'm going to talk about one of my favorite topics today, about malaria. And this is focused more on kind of clinical, an overview of the epidemiology, some of the clinical manifestations, a little bit about diagnosis and management. And hopefully I'll get through this whirlwind tour without putting anyone to sleep, and we'll see how I can go. And I always like to start out with a patient. So this is a blood smear, and it's normal, right? Almost. Okay, so let me tell you a little bit about the story that goes with this blood smear. There was a Mexican woman that went on this grand tour of Africa, to West Africa, to East Africa, on safari, visiting all these sites, and she was staying in Paris on the way home, and while she was in Paris, she felt like she got the flu. She was achy and had a fever, and she just got tired of it, so after a few days, she got on a plane, headed across the ocean, and landed at Intercontinental. She fell asleep on the flight, and when she got to Intercontinental, they couldn't wake her up. So, patient who's been in Africa with a fever, rushed to the medical center, and people did all these diagnostic studies, and in the middle of the night, an ID consultant said, well, rule out malaria. So I'm not going to mention the place this was done, but they ruled out malaria, and they said, well, we're going to do this properly. We're the best medical center, and so the proper way is to do a Guillain sustain. There's no one to do the Guillain sustain at night, so we'll do that the next morning. So the next morning, she had a Guillain sustain blood film done, and you might look at that Guillain sustain blood film and notice there are all these little things inside of the red blood cells. So you're at MD Anderson, so you're used to thinking about abnormal cells, and you realize that red blood cells shouldn't have things in it, particularly not 60% of them. And so she was diagnosed with Plasmodium falciparum cerebral malaria. So the ID consultant found out about this, and after he, dealt with the acute trauma of not having known this for a while, arranged for IV therapy, exchanged transfusions, and she kind of gradually woke up. The parasitemia got better, but she developed progressive respiratory failure, ARDS, and died. So this is a case from the Texas Medical Center of fatal malaria. So, well, what is malaria? Well, it's an infection by protozoan parasites of the genus Plasmodium. And we now realize that there are 5 major species that infect people. Plasmodium vivax and Plasmodium falciparum is probably the most common and the most severe. Vivax and Ovale are also common. Ovale, we're probably going to break that down into 2 species soon. Plasmodium malariae is a rare form, and we're starting to realize that this organism, Plasmodium knowlesi, is a monkey malaria that's turning out to be an important pathogen in South Asia and Southeast Asia. They're all transmitted by female Anopheline mosquitoes. Why am I picking on the women? Why just the females? Well, the male mosquitoes are vegetarians. They only drink nectars and fruit juices. The women take blood meals to make their offspring. And so it's the females that actually are the problems with malaria. And so there's a wide global distribution of this organism. It used to be common in the US. Prior to World War II, there were 20 to 30,000 cases a year in Texas. My uncle had malaria growing up in Kentucky, of all places. But now it's pretty much in the tropics, but nevertheless, it's a major disease. So there are thought to be about 247 million people that get malaria each year, maybe 800, 900,000 deaths. Most of the deaths are in Africa, and most of their deaths are in young kids. So about 5% of people in the world get malaria each year. It's not a rare disease. Well, we used to think, well, can't we control this? And there was a big effort in the 40s and 50s and 60s to try and get rid of malaria. And we realized that we introduced a cheap medication, chloroquine. We started using DDT to beat down the mosquitoes. And a lot of places, malaria almost went away. So outside of sub-Saharan Africa, it had largely disappeared. Venezuela, malaria was pretty much eradicated. And then a couple things happened in the 1960s. The parasites got resistant to chloroquine. The mosquitoes started to get resistant to DDT. And we stopped using DDT because of environmental concerns. And when that happened, malaria rebounded and has been gradually increasing between the 60s and the year 2000, in which a new round of eradication took over. But prior to that, it was actually a growing problem worldwide. So if you look at where malaria is, now it's pretty much distributed pretty widely in the tropics, in areas where you have mosquitoes, which is pretty much everywhere. The greatest burden of disease is in sub-Saharan Africa, spilling across the Red Sea into the Arabian Peninsula, but there's also fairly heavily endemic areas in Asia and the Amazon basin in South America. If you look at the incidence by regions, by far the highest incidence rates are in sub-Saharan Africa. And the key to the epidemiology is the mosquito. So where you get mosquitoes and people exposed to the mosquitoes, you get malaria. So standing water, as you're seeing here, puddles, drainage ditches are all a great place for Anopheline mosquitoes to grow up. Now you can get malaria spread by other means. You can transfuse infected cells and they can cause malaria. We've seen a few cases in the Texas Medical Center, post-op fevers caused by malaria. That's not usually on the fellow's differential diagnosis. You can get it from IV drug abuse, and mother-to-child transmission is another route of transmission of malaria. But most of the time, it starts out with the female Anopheline mosquito. When they bite, they inject the sporozoite forms in their saliva. Within a couple minutes, the sporozoites make their way to the liver and end up invading the hepatocytes. In the hepatocytes, they divide and form progeny. They rupture the cells, and then they bind to and are engulfed by the red blood cells. It's funny I say engulfed because they actually induce the red cell membrane to swallow them. You don't think of red cells as phagocytic cells, but they are for Plasmodium parasites. Inside the cells, they enlarge, they divide, and they eventually rupture and invade other cells and have a life cycle in the blood. Some of them then differentiate into the male and female gametocytes, and inside the mosquitoes, these form other progeny. So the major species of parasite varies by region. In Africa, Papua New Guinea, and Haiti, it's almost all Plasmodium falciparum. In Central and South America, most malaria is due to vivax. Similarly, in North Africa and much of the Middle East. But there are some areas, East and Southeast Asia, Oceania, parts of the Amazon, where you can have a mixture of species. So why does vivax and ovale spread in other areas? Well, they've developed a peculiar way of surviving when there aren't mosquitoes around all the time. So what's a poor parasite to do if there are not mosquitoes around all the time? And vivax and ovale take on this strategy. Well, why don't we just go to sleep in the liver for a little bit? We'll take a long nap, and maybe when we wake up, there'll be mosquitoes again. So vivax and ovale have taken the strategy of adapting to areas where there's not continuous mosquitoes by laying dormant in the liver, coming out weeks, months, or even a few years later. So how does malaria make you sick? Well, the parasites per se don't cause a lot of problems. But when the red cells are ruptured, there are some parasite molecules that have glycoinositol tails on them. They interact with toll-like receptors and activate them. So what happens when toll-like receptors are activated? They lead to secretion of cytokines. The cytokines cause symptoms like shaking chills, fevers, and if it goes away, sweats. Maybe some headaches. So those are specific, and you only think of malaria when you have shaking chills, fevers, and headaches, right? You go on rounds in the afternoon and you see a patient with shaking chills and fevers, you think malaria immediately, right?
Unless they're on amphotericin B.
Right, exactly. You get the same thing from amphotericin B, you get the same thing from gram-negative bacteria. So Plasmodium falciparum has a second thing that it can do. Falciparum has adapted to the host by thinking, well, you know, if I keep circulating those, I have to go through the spleen, and the spleen's going to get rid of me, and I don't want that to happen. So the way the parasites adapted to get around being cleared in the spleen is by putting knobs in the surface of the red cell. The parasite actually secretes proteins that form knobs on the surface of the red cell. The knobs, the proteins, actually a third of the amino acids are histidine, so they're called histidine-rich proteins that cause formation of knobs. And inside the knobs, the parasites inserts specific molecules that allow the red cell to bind to postcapillary venules. Therefore, the red cells can get sequestered away from the spleen, which allows the parasite numbers to grow and get to large numbers. Which is fine for the parasite, but what happens to the host? Well, if your postcapillary venules are clogged with parasites, that's not good. So if your brain capillaries are plugged with parasites, that's not good, right? If you're, and so what happens is you get hypoxia, you get nitrous oxide release, you get free radicals, and those cause organ damage, and there are various organs affected. So the main symptom from malaria is a paroxysm of shaking chills, high fevers, and if it goes away, sweats. With vivax and ovale, they can even get synchronized, so you have fever spikes that are every 48 hours. For some reason, the malariologists refer to that as tertian malaria, so they count days 1, 2, 3. I would have said every 48 hours you know, but they say tertian malaria. So if you have somebody with a fever every 48 hours, think malaria. How often do you see that in patients with malaria? Maybe 20% of cases at most. So it's not that helpful. So why is falciparum so dangerous? Well, in addition to it can infect red cells of all ages, it multiplies pretty readily in the liver stage. It's shorter than with the other parasite and makes more progeny. You have this sequestration mechanism with cytoadherence, and it causes capillary leak syndrome, and the result is you get a lot of end organ damage. Cerebral malaria, renal malaria, pulmonary disease. So again, how does malaria, the parasites, this is showing a parasite that's causing the red cell to ingest it. Here's a picture of some of the knobs on the surface of an infected red cell, and those end up leading to sequestration, packed vessels full of parasites, and rosetting, and those things lead to organ damage. So if you've got cytoadherence and rosetting, you get microvascular obstruction. In addition, that obstruction plus volume depletion leads to metabolic acidosis. Red cell destruction causes severe anemia, worsening metabolic acidosis. Acidosis, microobstruction leads to cerebral disease, respiratory disease that can lead to death. Again, so the parasite, this mechanism of adhering is very important to the parasite. So it turns out that about 5% of the malaria genome is devoted to these erythrocyte membrane proteins. And those different proteins are expressed one at a time, and they allow the parasites to adhere to different areas. Some of them bind chondroitin sulfate, which is found in the placenta, and you end up with placental malaria. And if you get immune to those, you aren't going to have placental malaria. So malaria in pregnancy tends to be worse in the first time you get it because that specific cytoadherence mechanism is available. Other parasite molecules bind to ICAM1 that's found in the brain, and if you do that, have those molecules, you get the brain clogged with it. Others cause rosetting and other things. Interestingly, the vessels in the eye and the ones in the brain are very similar. So actually, if people have cerebral malaria, you can look in the eye and see some areas of ischemia that are one of the physical signs of cerebral malaria. You can look in the eye and diagnose cerebral malaria. There are some host factors that are important in combating malaria. Most of the hemoglobinopathies, including thalassemias and sickle cell disease, actually protect against malaria to some extent. And it turns out that this is a prospective study of 1,000 kids in a malaria highly endemic area in Kenya. And they found in this case series that if people had normal hemoglobin, a number of the kids were dying. If they had sickle cell disease, they died from sickle cell. But if they had a sickle cell trait, the survival was actually better than in the normal hemoglobin. And so it's such an important selective pressure that the reason we have sickle cell disease and a lot of the other hemoglobinopathies persisting is because of the protective role against malaria. So what are the symptoms and signs of malaria? Well, we reviewed a series of cases in the early 90s from Houston, and the symptoms tended to be fever, chills, and headache, right? So every time you see somebody with fever, chills, and headache, you think malaria, right? Well, about half of them had nausea and vomiting. Fever, chills, nausea, and vomiting, that makes you think malaria, right? Abdominal pain? Okay, so there's nothing specific about it. So that's the bottom line. The problem is that it can cause a lot of syndromes, but most of them are nonspecific. So I'm going to talk a little bit in the next part of the talk about the clinical syndromes that you see. The most common one is an undifferentiated febrile illness or uncomplicated malaria. On top of that, you can get severe disease with organ damage, including the brain, kidney, lungs, etc. You can get hypoglycemia. You can get a illness that looks all the world like CLL called hyperreactive malaria splenomegaly syndrome. You can get nephrotic syndromes and pregnancy complications. So cerebral malaria is perhaps the most severe form of disease. And people come in with a febrile illness with altered mental status. You can see some seizures. This patient with tonic gaze to the side. You can get posturing. You can get really just very ill, altered mental status. If you look carefully, sometimes you can see hemorrhages or ischemic areas in the retina. If you do a scan, you may see some cerebral edema. Tends to be diffuse, nothing focal about it. So you may think that the patient has meningitis or encephalitis, which is what the patient that I told you about who was treated in the med center initially was thought to have. The only somewhat specific sign has been looked at fairly recently was this observation that you can have areas of whitening in the fundoscopic exam or in areas of hemorrhage occasionally in retinal exam, but it takes somebody who knows how to do a fundoscopic exam, which seems to exclude all the current generation of house officers. Pulmonary disease, very frequent to get lung involvement with malaria. And the main mechanisms is a capillary leak syndrome. So you're getting a non-cardiac pulmonary edema. And the factors in this include acute cytokine release and maybe some injury from cytoadherence. It's particularly problematic in pregnant women and often occurs late in the presentation. So they may come in looking okay, and then you see they're hypotensive, we'll get them lots of fluids, all the fluids end up in their lungs, they drown and die. It really requires careful attention to fluids. So malaria, unlike bacterial sepsis, you probably want to make sure to give enough fluid so that they don't get ischemic and renal failure. In malaria, you want to be careful not to drown them. So be very careful with fluid input in malaria cases. They can end up with respiratory failure. They can end up with pulmonary infiltrates. I've seen several cases that were thought to have a pneumonia because they had a pulmonary infiltrate and a fever. There's more to pulmonary infiltrates and fever than pneumonia. You can get the same thing with malaria. You can get sepsis from malaria. These are ischemic toes from a hypotensive patient. The parasites are causing acute cytokine release. You can get hypotension with that. You can get capillary leak syndromes with that. So you have to be very careful. Just because someone's hypotensive doesn't mean they don't have malaria. You can get nephrotic syndrome from malaria, particularly Plasmodium malariae. In this case, you got chronic infection, circulating immune complexes, probably relating to nephrotic range proteinuria. And it can go on for a long time. I think 50 years after infection, people can have a chronic Plasmodium malariae infection along with nephrotic syndrome. Renal failure can be a particular problem with malaria. Severe disease may involve the kidney. That can be either from ischemia or also from hemoglobinuria. So if you've got a lot of hemolysis release of hemoglobin, the hemoglobin in itself, if you've overcome your binding capacities, can cause kidney damage. It's often reversible, but may require dialysis on a short term, which is a bit difficult in a lot of centers where they have a lot of malaria. Malaria is a big problem in pregnancy. In sub-Saharan Africa, attention to malaria is part of routine prenatal care. So what do you do? Well, it used to be that every pregnant woman got put on chloroquine prophylaxis. What's wrong with that now? Doesn't work anymore. So now the recommendations in a lot of places are you just go ahead and give intermittent therapy for malaria for women that are pregnant. But malaria in pregnancy is associated with bad outcomes for both the mom and the baby. It causes maternal anemia, which is not good for the fetus. It causes low birth weight, not good for the baby, spontaneous abortions, and you can have congenital infections.
How you get control congenital infection?
Well, during the delivery, there's some exchange of red cells between the mother and the child. If they happen to be infected, they can proliferate in the baby. So you can infect the baby at birth.
So it's perinatal.
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 Right, right. So anemia is a big problem in pregnancy, and on top of that, if you have malaria, you can get severe anemia, as illustrated by this pale tongue and conjunctiva. The hemolysis from malaria can worsen the underlying anemia of pregnancy. In addition, iron deficiency, vitamin problems can be worse. And the management of malaria and prophylaxis is an important part of prenatal care in Africa. It used to be chloroquine, now tend to give several courses of Fansidar in highly endemic areas. So the congenital malaria is perinatal transmission of maternal red cells. Most of the infections are asymptomatic, and actually they usually are cleared spontaneously because the parasites don't like fetal hemoglobin. They just kind of spit it out and say, this is not good. They want the good stuff. If they can persist, though, after a couple weeks, the parasites start growing and can cause a clinical infections of malaria. So malaria is among the causes of neonatal sepsis in Africa. Neonatal sepsis, think malaria, right? Post-op infections, think malaria. Now, interesting, there's no liver involvement, so you don't have to worry about latent liver forms if you're treating a congenital malaria. Hypoglycemia can be a problem in malaria. Results from the infection, increased oxygen demand, anaerobic metabolism, lactate production. On top of that, quinine and quinidine cause, if they're used for treatment, cause insulin release. So you can have synergistic causes of hypoglycemia. And on the differential of cerebral malaria is also malaria with hypoglycemia. So one of the first things you want to do if someone comes in the hospital in a coma, possibly from malaria, is give them glucose. So there's another syndrome called hyperreactive malaria splenomegaly. It used to be called tropical splenomegaly syndrome. And it's characterized by seen in people in endemic areas that develop chronic splenomegaly. They have elevated globulins and high antibody titers to malaria, but the smears are often negative. They often have a lot of lymphocytes, including in the liver, and interestingly, it responds to malaria treatment and prophylaxis. The splenomegaly can be massive, and with that you get pancytopenia, anemia, leukopenia, occasionally lymphocytosis, and thrombocytopenia. And this can be complicated by infections, splenic infarcts, bleeding, and it actually can transform to CLL. So chronic splenomegaly in an endemic population, think malaria even if you don't see the parasites on the peripheral smear. Yeah, I visited some colleagues in Kenya, and they presented me as an unknown case of reactive malaria splenomegaly for their grand rounds. Everybody else knew what it was, and they got me up on stage to discuss it. Fortunately, I managed to list it in my differential diagnosis, so I didn't embarrass myself too much. There's a syndrome called blackwater fever in which you get acute hemolysis, hemoglobinuria, and renal failure. And that's in part due to just the bad malaria, but it's also in part due to drug-induced hemolysis. So it's a combination of factors. You get black urine, black water, and you have fever. So that's blackwater fever. So we used to think, well, all the bad malaria is from falciparum, right? Well, that's wrong. It turns out that there have been a number of studies recently that show that you can have severe symptoms with Vivax as well. And we didn't used to think so, but you can jaundice, renal failure, severe cytopenias, and even cerebral malaria and ARDS have been described with Vivax. We had a case a few years ago at Ben Taub where the patient presented with pulmonary infiltrates and malaria and hypotension, and we thought, well, this has got to be falciparum, treated him for falciparum, but it all looked like Vivax, so we sent the smear off to the CDC, they did a PCR, and found out it was pure Vivax. You can get severe malaria from Vivax. So when you think about malaria, malaria deaths are preventable. And the key to making a diagnosis of malaria is, number one, think about it. If you don't think about it, you won't make the diagnosis. So pretty much the bottom line is fever from the endemic area equals malaria until proven otherwise. Fever from an endemic area is malaria. Malaria is an emergency. You need to evaluate them emergently. That doesn't mean doing the Guim sustains the next day. I think you all probably picked up on the fact that that was a problem with that patient I told you about initially. And if you've got falciparum, you probably should assume it's drug resistant unless you know they're from an area where it's all drug susceptible. So how do you manage malaria? First question, is it malaria? If so, what species? What's the parasitemia? Can you treat the patient with oral medications? If they have a lot of nausea and vomiting or are severely ill, maybe not. Are they from an area where there's drug resistance? Is there evidence for severe malaria? So the diagnosis depends on looking for it. We used to get lucky and we do CBCs stained with right stain, and the techs would look at them and pick up the parasites by mistake. Nowadays, most smears are done by machines. And you know, the machines, they aren't trained to pick up malaria parasites. Now, some people have tried to train them to do that, but even so, they just don't get it. They're used to looking at white blood cells, and they just don't get the malaria smear. So you really, if you want to diagnose it by smear, you need some person with 2 eyes and half a brain to look at the blood smear and make the diagnosis. There are 2 types of blood smears. There's the thick smear, where you just take a drop of blood, let it dry on a slide, you lyse it with water and then stain it, or a thin smear. The thin smear is the same thing as a CBC smear, okay? And then you stain them and look at them. The thick smear has the advantage that it's thick. That means you've got lots more parasites in a given area. The problem is it distorts the morphology and you can't tell the species as well, and it's harder to read by inexperienced people. Most lab techs in the US can read a thin smear. Most lab techs in the US can't read a thick smear. And 2 in the morning when you think someone has a severe malaria infection is probably not the time for them to be learning how to read a thick smear. So if they've at least got a thin smear, have them look at it. And if you're lucky with the thin smear, you can see lots of individual parasites. The thick smears are a little bit more hard to differentiate, as you see below. Interestingly, we're now switching more away from microscopic diagnosis to antigen detection. And now there are a number of so-called rapid diagnostic tests, or RDTs, that can be used at the bedside to make a malaria diagnosis. And they usually involve taking some blood, putting it in a lateral flow test, lysing the red cell and using some buffer to capture antigens, and then coming back with a second antibody that makes the line. So you'll have little smears where you have a negative with a control here, a positive here, a positive for mixed infection, and positive the other one. And there are a number of different assays now. Looking at them overall, comparing smears with the rapid diagnostic tests, overall the rapid tests are actually a bit more sensitive than the smears, using PCR as a gold standard. The specificity is very good for both, maybe a little bit better for the blood smear, but really quite good. For falciparum, you know, they're both pretty good, but for Vivax, you can miss it on the smear. You can miss with the RDTs also, but in general, they perform better. So increasingly, areas where you don't have well-trained technicians, the rapid tests are being used, and they're being rolled out more and more in Africa for a diagnosis of malaria. So in malaria, delay is the main cause of bad outcomes. So the delays can include delays in getting to medical care. So our lady I told you about was in Paris for a week, not getting medical attention. That was her mistake. But once she got here, the diagnosis wasn't considered for several hours. okay, once it was considered, the diagnostic test wasn't done for a few hours. In this case, therapy was started promptly, but I've seen other cases in the area where patients have died because the drug treatments weren't started in a timely fashion. So, a little bit about treatment. The treatment of chloroquine-sensitive malaria is chloroquine. Chloroquine's a great drug. It's safe, including in pregnancy. It's easy to take. There are IM preparations some places. Unfortunately, we've lost it most places. But there are areas where chloroquine still works with Plasmodium falciparum. It's pretty much universally effective for Vivax, ovale, and malariae. But for Vivax and ovale, you've got that liver phase. The liver phase doesn't respond to our drugs for the bloodstream phase, and so you have to use a separate drug for that. And typically the drug is primaquine. The problem with primaquine, if you have G6PD deficiencies, it can cause further hemolysis, so not a good thing. Unfortunately, the areas where they have G6PD deficiency happen to be the areas where they have more malaria. So it's problematic getting at that. But if you have rapid access to G6PD testing, you probably should do it before using primaquine.
This term is an epidemiological term, chloroquine-resistant malaria. There is no other test to...
Well, yeah, there are PCR assays for that, but generally it's not been described very often in the non-falciparum species. And the falciparum species, well, I'll talk about chloroquine resistant a bit more if you'll permit me, okay? So chloroquine came into widespread use in the 1940s. By the late 1950s, about 10 years later, separate episodes of resistance emerged in Colombia and Thailand. The one in Colombia spread throughout South America. The one in Thailand gradually spread throughout the Eastern Hemisphere to the point where it's now universal throughout Africa. There are a few areas where you still have chloroquine-sensitive falciparum. This side of the Panama Canal, the island of Hispaniola with Haiti, a few foci in South America, and a few scattered areas in the Middle East still have chloroquine-sensitive disease. Most places, however, where you have falciparum, you have chloroquine-resistant disease. And in Southeast Asia, you're getting resistance to mefloquine. So how do you treat chloroquine-resistant malaria? Well, in the 2010s, I think the answer universally now is you should treat them with artemisinin combination drugs. So how many of you have never heard of artemisinins? No one's willing to admit that. Okay. So you all know all about that, right? Well, I'll talk a bit more about it. But in general, the main treatment is artesunate is the main IV drug. It should be used with a second drug. And some combinations of different artemisinins are probably the oral drugs. And if you can't get the artemisinins, quinine or perhaps quinidine may be alternatives combined with a second drug like doxycycline or clindamycin. And atovaquone, proguanil, or mefloquine are less desirable alternatives. So what are these artemisinins? Well, they were derivatives of a wormwood plant in China, and they kill the organisms really, really quickly. Been widely used for a while in Asia, and now are becoming to be recognized as the best drugs. They're generally pretty safe in most trials. There were some concerns about neurotoxicity of some of them initially, but that doesn't appear to have borne out in clinical trials. And artesunate is probably the one that's being most widely used in severe disease. There's IV and oral forms. In the US, the IV form is stocked at major quarantine stations, including Intercontinental Airport. So there's IV artesunate at Intercontinental. It's not licensed, but is available. There's great experience with the oral drugs in uncomplicated and increasingly They're being used in complicated disease. If you can take PO, there's rapid absorption, and it kills the early stage rings very quickly. There have been a number of randomized trials of artesunate versus quinine in severe malaria. And if you look at this meta-analysis figure, you can see that overall there's a statistically significant improvement in survival in patients with severe malaria treated with artesunate compared to those treated with quinine combinations. And that includes a number of studies in Asia, including a large one with 700 per arm, and also more recently large studies in Africa with thousands of patients per arm. Survival advantage, it's a better drug. If you've got a severe malaria, get on the phone, get the drug shipped down from Intercontinental.
But it's still not licensed, true?
No, it's not licensed.
Means you need IRB approval.
No.
No?
You need to tell your IRB afterwards that you've used it. No, it's actually an emergency IND that CDC has. And so with that emergency IND, you're allowed to give the drug pending. Yeah. So there are also a number of artemisinin combinations that are being rolled out for malaria treatment worldwide. Some of them are multiple drugs together, some of them are separate. Initially, the artemisinins were used with tetracyclines or mefloquine, but now there's some combination pills where everything's packaged together. One of the more interesting ones is a drug called Coartem. It's licensed in the US. I think the pharmacy at Ben Taub keeps it stocked. It's a combination of artemether and lumefantrine, which is a mefloquine-like drug. You take one pill, you take the drugs, one pill usually twice a day for 3 days, and it's curative for most moderate to even mild to moderate infections, and can work in severe infections if the GI tract's working. So there's licensed artemether, Coartem, in the US. It's a good thing to think about if you've got a moderate to severe case. There are also artemisinin suppositories that are being developed by WHO, and the idea here is that if you can't get an IV in and they can't take PO, you can stick things up their bottom and get the same effect very quickly. And this is being developed as something that can be rolled out into villages in isolated areas. So as I mentioned with Vivax and Ovali, you have this dormant liver stage that can lead to relapses occurring months or years later, as opposed to recrudescences from incomplete treatment of falciparum. So because of that, you'd use primaquine. So when would you use IV therapy for malaria? Organ involvement, lung involvement, CNS involvement, pulmonary edema. If they can't take PO, a lot of malaria patients have nausea and vomiting. If they have nausea and vomiting, you might think about starting out IV. And it's a little bit controversial, but some people recommend using IV therapy for hyperparasitemia. What's hyperparasitemia? Hyperparasitemia is in the eyes of the beholder. So I think probably it's not necessarily an indication. So probably what you should focus on is if there's organ damage, and particularly if they can't take oral drug reliably. Well, what do you do initially with severe malaria? Well, like anyone else, you want to make sure their airway's protected, particularly if they're in a coma. If they're kids, you want to do weight-based therapy. You should get them on anti-malarial drugs promptly. You can do exchange transfusions. What's that? Well, you take out the bad blood and give them good blood, right? And that should get rid of the parasites, right? Well, where are the falciparum parasites? Yeah, they're in the capillary. So actually, it's not as useful as you'd think, because where the parasites are the highest and doing the most damage, you're not removing them. So it's controversial whether this even works or not, but it's something that you should at least consider. You need to assess them clinically. You need to think about whether they've got hypoglycemia, assess their fluid status. Don't drown the malaria patient because their capillaries are leaking in their lungs. Give them enough fluid to make sure they're not volume depleted, but run them dry. Initial labs, you need to look at their hemoglobin. Do they need transfusion? Monitor their urine output. They might need antipyretics. People used to think, well, they've got cerebral edema, we should give them steroids. A randomized trial showed if you give them steroids, there's a worse outcome. So it's not a good idea. And then you need to think about whether they have a bacterial infection as well. If they're altered and febrile, you probably should do an LP to make sure they don't have meningitis. If they are hypotensive, you probably should put them on antibiotics because it turns out in Africa, just because you have malaria doesn't mean you don't also have bacterial sepsis. And in fact, malaria alters the neutrophil function to the point it predisposes people to Salmonella bacteremia in particular. Think about whether they need anticonvulsants, vitamin K. Okay. So in terms of what can we do to control the infection and prevent it from coming back, not in the individual, what can we do to control infection in the community? And there's been a revolution recently in the public health management of this, such that over the last 10 years or so, malaria is actually retreating worldwide. And the key things that are being done to get this to turn around again are insecticide-treated bed nets. The mosquitoes bite, they transmit the disease. If you don't get bitten, you don't get infected. And most of the biting is during the evening and nighttime. And so the simple technology of sleeping under bed nets and coating the bed nets with insecticides has actually had a remarkable effect on malaria worldwide. We're now realizing that we need to make a parasitologic diagnosis and not throw out antimalarials in Africa. The reason for this is if you use them too much, you're going to lose them. So let's make a diagnosis and see that we're treating correctly. Artemisinin and combination therapy should be used. Never use a drug alone because that's a good way to select for resistance. And intermittent preventive therapy in some centers is being used empirically in high-risk pregnancies and in infants that are from areas where they have a lot of malaria. Just go ahead and treat everybody. Part of pediatric care, part of prenatal care. So the bed nets are now being seen as really an important control measure, and by putting insecticide in them, even if there's a hole, the mosquitoes still don't get in them. And the good thing about bed nets is they work better where there's lots of mosquitoes and less malaria because people will sleep under them to keep from getting bitten by the other mosquitoes. The problem with them is it's hot underneath the bed net, and so some people don't like bed nets because they say, well, I can't sleep as well. But where combination therapies have been used, this was the number of malaria diagnoses in Zanzibar when they put in place procedures of bed nets and combination therapy, they just about eradicated it. And that's been happening throughout Africa. There's now half as much disease as there was 15 years ago. On a personal side, there's some things that we can do, particularly among travelers, to keep from getting infected. The mosquitoes bite in the evening and night, so don't get bitten by mosquitoes. So wear long sleeves and long pants in the evenings at night. Think about insect repellents. If you're going to a malaria endemic area, the most fashionable cologne is called DEET. You want to smell like DEET, because if you smell like DEET, the mosquitoes will not bite you. You should generally sleep behind screens in air conditioning or under bed nets. But if you do that, make sure that there aren't the mosquitoes inside of the bed nets or inside of the screens, because if there are mosquitoes inside the screens won't help you. So what happens if you've got them inside of the screens? Well, bomb the area with an insecticide prior to sleeping in the area. You can impregnate clothing as well as nets with insecticides, and then finally chemoprophylaxis. There are a bunch of different drugs that can be used for chemoprophylaxis. Chloroquine works great if you've got chloroquine-sensitive malaria. So if you're going to Central America or Haiti, that's probably reasonable. But for most other areas, that's not a good idea. There are 3 drugs commonly recommended in the U.S. mefloquine, atovaquone, proguanil, and doxycycline. Doxycycline I call the student drug. It's cheap, it's generic, you can buy it, but there's some side effects. It can make some people nausea, can cause a pill esophagitis, and every once in a while can cause photosensitization. So there may be some intolerance, but most students are willing to put up with stuff just so long as it's cheap. Mefloquine, I call it the missionary or MSF drug. Why would that? Well, it's once a week. So that's a little bit easier to take if you're going someplace long term, to remember to take it once a week. It can cause some nasty side effects like CNS toxicity, and people can go loopy, although most of the time most of what's blamed on mefloquine is actually the person went loopy, unrelated to it. But there are some significant CNS side effects, and so if people, you need to give them a few doses beforehand to make sure they're going to tolerate the drug before long-term use. Has to be continued for 4 weeks after return, as does doxycycline. And the third drug we commonly use for malaria prophylaxis is atovaquone proguanil. I call that the businessman's drug. Easy to take once a day. You only need to take it a week after a short trip, so not nearly as long of exposure. But it has this common problem. It erodes holes in your wallet. It's very expensive. So it's not appropriate for long-term use, but for a short business trip, it's probably the anti-malarial of choice. The other one I mentioned here is primaquine. The drug for the liver stage can be used in areas where you mainly have vivax as the main malaria species, and so you don't have to take it as long afterwards. And you know, if they really don't have much malaria where you're going, maybe you just want to watch and wait.
And which one do you use in pregnancy?
In pregnancy. So chloroquine is safe in pregnancy if they're going for a chloroquine sensitive area. Mefloquine is generally safe in pregnancy. There is a slight increased rate of spontaneous abortions in the first term, but there have been no congenital anomalies associated with mefloquine. But really, if someone's pregnant and seriously thinking about going to an area, you have to at least ask them, do you really want to go? Okay, so future directions, what are we doing to control this? Subsidized bed nets, artemisinin combinations, and rapid diagnostic tests are being rolled out in areas. And there's a lot of work on vaccines. Irradiated sporozoites, if you give them IV, seem to work, but how to roll that out is not clear. Attenuated organism, recombinant antigens. But so far, we're a long way from having anything that will give sterile immunity from vaccination. And of course, there's need for new drugs. And I think I'll call it quits there and ask if you all have any questions.
In this country, I've heard many experts say that if you have a patient with malaria, you should hospitalize them until you feel it's controlled because of a lack of experience and the possibility of nausea. Even if you plan to treat him orally, what do you think about that?
So the question is, should we hospitalize everyone with suspected malaria?
With malaria.
Well, with malaria. I think that's probably a bit of an overreach, particularly if you diagnose them with Vivax or Ovali. Most of the time they're not going to be very severe. If they have falciparum malaria, you have to be very careful about sending people with falciparum out who are naive and not semi-immune. In the endemic population, the semi-immune population tends to have a milder form of disease, and so often malaria is managed as outpatients in endemic areas. But you know, here they're at risk for severe disease, and there's also a risk because you might encounter lawyers or other reptiles that could potentially make your life miserable if there's a bad outcome. And so I would be very careful about it.
Argument is that very few, in very few places can they differentiate between falciparum and others. Usually they just say malaria, and you're relying on somebody who has never seen it to look at a book and tell you, and to find the gametocytes is not easy. So.
Well, but again, if you've got a low-grade parasitemia and you see enlarging or dividing forms that look like vivax, I think it's probably safe just to go ahead and treat them. Yes?
Is there any theoretical contraindication for donor organ transplantation or transmission of malaria in a kidney transplant, for example?
Well, yeah, no, there's...
But you had malaria 20 years ago. Is there a way a dormant parasites in tissues of organs that we don't really think about?
Right. Well, so you know that Plasmodium malariae in particular can be around for a very, very long time. And there's blood in the transplanted kidneys, so potentially you could transplant Plasmodium malariae, certainly. The more acute ones would be potentially a problem. Clearly, you can transfuse malaria. So, could we transplant it as well? Probably. Here we don't think about necessarily screening people for malaria. So I suppose if someone got an organ from someone from an endemic area, there is a theoretical risk of transplant-associated malaria as well. I didn't mention that, but that's a good point.
Are the species of Plasmodium that infect humans specific to humans, or do they infect other mammals? Are we kind of the primary host or accidental hosts? Or
so for Falciparum, Vivax ovale, and malaria, humans are the main hosts, although they can infect primates as well. With Knowlesii, monkeys are the main species, reservoir, and humans can be infected as well. So it's most of them are human diseases primarily.
Do we know whether those species were introduced at separate times? Like, is Falciparum more virulent because it hasn't had as much time to kind of co-adapt to the humans? The idea that maybe it's not a great idea to kill your host. Maybe ovale and Vivax have had a longer time to. Do we have any idea about that?
There's literature on that, and I can't answer your question off the top of my head, so I don't know the answer. They seem to have different. Falciparum seem to have developed from avian species, whereas the others are more mammalian. So whether the Falciparum per se is more recent, I can't tell you.
Have anyone looked at clindamycin as prophylaxis? Because it can be used as treatment, but...
Well, generally there's a preference for longer acting agents for prophylaxis. So Clinda has a pretty short half-life, so you'd be having to give it several times a day. In addition, you'd be potentially creating risk for C. difficile and other things. So I don't think Clinda's been looked at. Azithromycin was tried and didn't work very well. Yes, sir.
So I got a call this morning at 6:30 in the morning from one of the staff here. She was in Tanzania last month, came back to the end of last month, and last week, high-grade fever, chills, and increased LFTs. She didn't take any prophylaxis. I referred her to Javier, so is it malaria, you think?
Well, it could be, but fever, chills, and elevated liver enzymes from Tanzania has a long differential diagnosis. But if you look overall at febrile illnesses in people who've traveled to Africa, about 60-something% of cases turn out to be malaria. So that's more common than the flu in people that have visited there. So you have to think of that as high up on your initial diagnosis. But from what you tell me, it could be dengue or Rift Valley fever, chikungunya virus, leptospirosis, relapsing fever, African sleeping sickness. You know, the list is or acute hepatitis E. Or E.
She went to Tanzania, came back here, and then went to Taiwan for a week, and then came back. She got sick in Taiwan.
So, you know, there's a long list of potential causes.
So chikungunya is common in Tanzania?
Well, there was an epidemic, there's been an epidemic of chikungunya that's been migrating around the Indian Ocean. In the late 2000s, I think around 2006, 2007, there were over 1 million people infected in India. So, I mean, this has been a very common viral infection, although chikungunya, typically you'll have more joint involvement, so people will often complain of arthritis or arthralgia. What?
This is Tanzania, Africa.
Tanzania is on the Indian Ocean.
Yeah.
I'm sorry to...
So, what is your opinion about those niche areas of parasitology? Is it better in a patient who comes with fever and headache from an African country? I'm not going to say the name.
Yeah.
That's my geography. But to be referred to somebody like you, or to a travel clinic, or to a competent ID doctor with a CDC?
Well, I think if
guidelines?
you've got somebody with a fever and potential malaria, that's a medical emergency, and so that needs to be addressed immediately. So you can't, you know, you try to get in my clinic in a day or two. It's not going to happen. You know, I mean, that's a medical emergency and cause for emergency evaluation by the for potential malaria.
Maybe my question was not very specific then. Should the average physician who hasn't seen the critical mass of cases evaluate the patient and seek advice on the spot from CDC or from some expert,
yeah,
or play around?
I think if you've got a moderately severe case, the CDC has a drug service that provides the artesunate, and I would not hesitate to call the. I think anybody should call the CDC up pretty quickly if you've got someone with moderate to severe malaria that's sick enough that you're hospitalizing them and, you know, worried about IV therapy. The IV therapy is only available from CDC anyway, so you might as well go ahead and call them.
You have a malaria hotline that
Yep.
Yes,
I use on weekends, and you call them
Yep.
and they tell you what everything. You can send them the slides over there.
Yeah, hi.
How long after Vivax or viral malaria infection can hepatitis provoke, regardless of the disease? I think it's usually the first 1 or 2 years, but can it happen after 10, 20 years?
Yeah, it can happen after a really prolonged period of time. Although it gets confusing because if it's too long, you sort of wonder whether they had gotten reinfected or not.
There was a New England Journal of Medicine case report from Greece that was 10, 15 years recurrence of.
But was that which species?
I think there was virus.
Okay. Because I know there's been a description of malaria going on for forever, but sure. But you can get relapses years later. So typically, though, most of the relapses are within weeks to months or a few years, but they can occur much later.
So if we got a severe case today, so who do we need to call? The malaria hotline or the airport?
You'll have to call the malaria hotline, and they can get the drug released from the airport.
Oh.
You just drive right on up there and ask for it.
Well, they'd probably give it to Sam if he did it. He's got a nice honest face, but
Being that you have chloroquine and mefloquine resistance, why do you speculate there hasn't been so much doxy resistance?
there's what?
That there's not really any increase in malaria with doxycycline.
Well, the advantage of doxycycline is it's a short-acting drug, and one of the good things about short-acting drugs is you don't have that end period on the curve when you're chronically exposing parasites to low levels of drugs. So it's less selective than chloroquine or mefloquine, which have 1 to 2 weeks half-lives and end up, sub-therapeutic levels being around for a long time.
And if you would travel, which one would you prefer to prevent it? Because I prefer like doxycycline prevents like leptospirosis and many other.
Yeah, it depends where you're going and for what purpose. So I think there are reasons to use all of the different combinations. All of them are preferable in certain situations.
Well, you're not a student anymore.
But George made a good point. So for example, if you're going to an area where there's a lot of leptospirosis, the doxycycline would actually help prevent lepto as well as malaria. If you're going to be hiking through the rice fields in Southeast Asia, you'd have to worry about scrub typhus, and the doxycycline could help prevent scrub typhus as well as malaria. So there are situations where that might be the preferred drug. And I guess it depends where you go. I mean, most of the time, then I've typically been in Central America. I don't bother because the risk of transmission is so low that I don't think you need to take the prophylaxis in most cases. But I went to a isolated area in the jungles in Nicaragua to set up a clinic one time and decided I better take some chloroquine then. I don't know. I've used all sorts of different ones.
There's another option, I think, for patients who refuse to take it on a daily basis, or to take a drug on a daily basis, and occasionally you have to use, which is to give them a treatment course in case they have a fever. Have you ever had to use that?
Yeah, you can do that. The problem with that is how good do you think they are at telling malaria from other causes of fever? It's hard to do. And and actually there's a poor correlation between the results on blood smears in Africa and actual whether people have malaria or not. I had one guy that kept saying, he kept being treated in Africa for recurrent malaria. The last time he developed the symptoms on the plane going over there, which seemed like a rather unusual timing. We did antibody tests and showed that he'd never gotten infected. So it's hard to make a diagnosis, and who are you going to recommend empiric therapy for and not have them evaluated for potential bacterial sepsis? That's the problem.
Even fungals, there are some spectacular reports of Mucor, disseminated Mucor in the case of acute falciparum malaria from acute hemolysis and availability of iron. So all the disseminated Mucor in Africa has been described in the setting of acute falciparum malaria.
Right. Right. Okay, thank you.